Yevle sir has requested Dr. Amol to please take over. Thank you, sir.
Good afternoon, everyone. I'm Dr. Krutika Thakur, pediatric consultant working in Jupiter Hospital. The case I'm going to present was a medical puzzle for us, full of twists and turns, provisional diagnosis, and surprising revelations, ultimately leading us to the final diagnosis. So this 9-year-old girl presented to us with headache since 9 days, fever since 6 days, abdominal pain and vomiting since 6 days, reduced appetite since 6 days, weakness and lethargy since 3 days, body ache and leg pains since 2 days. Headache was frontal in location, sudden in onset, gradually progressive. Sometimes it was associated with phonophobia and photophobia. It used to get increased with neck movements, not relieved by analgesics. Fever developed 3 days after the start of headache. Fever was insidious in onset, intermittent, high grade, 4 to 6 hourly spikes were present, and child was interfebrile, dull. Vomiting was non-bilious, non-projectile. There was no blood in vomitus. It was gradually progressive. Initially, 2 to 3 episodes were present per day, and then episodes increased to 8 to 10 times per day. It was also associated with loss of appetite. Abdominal pain was sudden in onset, on and off type. It was mild diffuse in type. For said complaint, she was taken to her family physician, but did not improve much with initial treatment. Initial laboratory investigation also did not reveal any diagnostic clues. Her CT brain was done, which did not show any abnormality. So what are the differential diagnoses here at this point of illness? Dr. Anjali, please.
So we have a 9-year-old girl who came for the first complaint of headache. And only after 4 days of headache, this child had fever. And the onset of the headache was sudden, and it was progressive, and it was not relieved by analgesics. So if you can go to the first slide, first, even before this. So if we have a child with headache, fever, vomiting, and the next slide you said that she was dull.
Yes,
Interfebrile dull. So if you take all these together, then one would think of a CNS infection. But in that, I'm not able to explain why the headache came first and 4 days later the fever came. So that is one of the things. And so if one has to localize, then I would say that the problem is in the CNS, and it's of an infective or an inflammatory kind of possibility. So what comes to mind is meningitis or even an SOL, because an SOL would have, first a headache which is not relieved, and then perhaps that fever was unrelated or the fever came later. But what we also commonly see, because the fever has gone on for 9 days, a meningitis that is going on for 9 days. So if you take the total history, so something that is going on for 9 days, any fever we say if lasts for more than 8 days, then we consider other infections, so perhaps cerebral malaria, or say something like rickettsial fever or typhus, or even brucellosis, which can cause headache, fever, dullness, and that kind of this. And just an out-of-box thinking is if that headache was because of, say, hypertension, and all these other symptoms are because of, say, pyelonephritis or some sepsis or something. So these are just out-of-box, but basically infection in the CNS and some severe infection. Yeah, but what is not explained is that for a child who has been ill for so long, the CT brain seems to be absolutely normal, and even the tests are all normal. So for meningitis, one would have expected that the counts would be high, or at least the CRP, which was done, if it was then
normal.
Yeah. So that's very, very unusual for an CNS infection that has been going on for 9 days.
Yes, ma'am.
But I'm not sure that a meningitis, the
Not
fever
many, but
would be.
fever. I mean, our problem was
Yeah.
why the headache first and after 3 days fever. That cannot be explained by any infection
But
which
we
is
know
occurring.
that we have treated so many meningitis, and if the child has fever, then no analgesic until the antibiotic acts is going to reduce IV antibiotics. So if the headache has not gone because of the analgesic, I don't think the fever would also go. I mean, it's a compounding thing.
But sir, after so but once the analgesic effect has stopped, if it is a infection, means like true infection or this thing, if the analgesic effect has stopped after that, fever might, there are chances it will come. But if the analgesic is round the clock, then definitely fever will get suppressed.
It can get
It
suppressed,
can get
and especially
suppressed.
if it's a low-grade
It's round the
meningeal
clock, low-grade
infection
fever. Yeah.
and it is increasing,
Yeah.
then it can happen if it's a
I-
just
yeah,
a diagnostic hypothesis. I mean, just to explain that still it can be a infection, although the fever has started again. Because, yeah.
Continuing with the case, she was evaluated by us for above mentioned complaints in OPD on day 9th of illness. Her vitals were stable, she was well oriented. Systemic examination was normal. So we worked her up for acute febrile illness. We kept in mind possibility of dengue fever. Her labs came out to be normal. In view of persistent headache and poor oral intake with lethargy, she was advised hospitalization on day 11 of illness.
Yeah, just if you can go one step behind, I just want to say that possibility of dengue fever after 9 days seems a little unlikely because any dengue by 7 days would go away. So that seems, and even the chronology of the symptoms, the headache first and
Fever
then the
later.
fever.
Okay,
So
ma'am.
it's only when the fever goes that the rest of the things come up in dengue.
Yes, correct. On examination on admission, she was afebrile. Her vitals were stable. Systemic examination was normal, except for presence of doubtful terminal neck stiffness, which was inconsistent finding because child was not very cooperative. So what are the differential diagnoses at this point of illness?
We are clutching onto straws. So if there is one finding that is there and that is terminal neck stiffness, I will take it as the finding and think of meningitis as the first possibility. Although we know that typhoid fever can cause meningismus and some terminal neck stiffness, but even in that event, I would still consider meningitis and think of, doing a lumbar puncture. Can someone give a mic because we can't hear clearly?
Okay.
In a child, this child had a history of protracted vomiting also, progressively worsening. So those protracted bouts of vomiting may lead to hypochloremia. That may be a cause for meningism, which is picked up by her like semi kind of meningeal signs. With this duration of fever and no clues on CBC and other things, I would like to look at the mediastinum of this girl, right? And maybe some parapharyngeal space. With that meningeal signs, looking at that meningeal, these are my two places I would like to concentrate at this point of time.
Okay, yes, sir. So on admission, we sent relevant investigations. CBC was near normal with HB of 11.5, counts of 10,000 and platelets of 3,95,000. CRP was just slightly elevated at 10.7. Blood culture was sent, which later on showed no growth. Urine routine was sent, which was normal. We got a fundoscopy also done in view of headache and fever, which showed no papilledema. MRI brain with contrast with MR venogram was done. So MRI showed frontoparietal meningeal enhancement. We got CSF studies done in which proteins were
Just
high.
can I say one more thing? If you go to the previous slide, you have said blood culture. Now, sometimes this blood culture, we have to wait for 4 to 6 days for anything to come positive.
Final, yes.
We are using one multiplex PCR fever panel, which includes rickettsia and chikungunya and all in one test.
Tropical fever
So,
panel.
no, it's not tropical fever panel. That is just CBC and other things. This is a PCR-based test, which analyzes 6 or 8, gives malaria, salmonella, rickettsia, chikungunya, and dengue. So it's a complex, multiplex PCR for fever.
Yes.
Yeah, no, that's just.
CSF showed high proteins, 199.3. Sugars were low, 54, with the simultaneous blood sugar level of 130. Cells were elevated, 246, with lymphocytic predominance. So she was started with injection monosef and acyclovir. Her gene expert and AFP both were negative. They were sent, which came negative. Her CSF culture and meningoencephalitis panel were sent. And there were no fever spikes since admission. So looking at the CSF picture, what are the thought process? What kind of meningitis can it be?
40 years ago, I would have said TBM. But now there are many other differentials to be considered because the proteins are high, more than 45, sugars are low, less than 60% of the blood levels, chlorides are 115, and cells are predominantly lymphocytes, although they are 246. So this looks like low-grade meningeal involvement, and at that time we used to call it meningoencephalitis. So viral meningoencephalitis, TB meningoencephalitis, or even immune-mediated meningoencephalitis.
CBC was normal. Lymphocytes were 8% and neutrophils were 88% lymphocyte. I knew, ma'am, you would ask that.
So she's already in second week of her illness, and over here we can expect even acute bacterial meningitis to have lymphocytic predominance. Sometimes we also treat them with oral antibiotics, so they may have alteration of the
Child
CSF
had
picture.
received oral cefixime
Yeah. So
outside.
yeah. And secondly, nowadays we are also seeing something like a MOG antibody demyelinating disorder, which will show very high cells and proteins on CSF, which will mimic like acute bacterial meningitis. So that is another thing. Well, non-infective ones I'm thinking of. And autoimmune encephalitis will not usually have such high cells and proteins. Usually should not have such high cells.
Onset progressive symptomatology with CSF pleocytosis, lymphocytic predominance. What more we want? I mean, investigate more for TB. Then all the other investigations come later.
Yeah, TB is the first. There is no doubt about
And
it.
partially treated pyomn
Yeah,
maybe
yeah, yeah.
because
Those are the first. Since she's asking for another differentials, I was at.
That is why gene expert also we had sent, but came out to be negative.
So again, gene expert,
Because
they
it
will
means-
tell us the kind of sensitivity, gene expert ultra, whether it was sent or plain gene expert, all those things I think do matter.
And I also differ whether oral antibiotics would treat or would cause so much change in the CSF to make it like a partially treated.
So 2-3 possibilities, as sir said. It could be like more of a TBM as sugar levels are normal. Even if someone are thinking about the partially treated, the sugar levels not be so high, means like 54. They could be around like 30, 34, some around. This kind of picture sometimes, as Rushabh said, can be seen in MOG or NMDR antibody receptor. This thing. So third thing could be like rickettsial infection. They can present this kind of a picture. And since the child is in second week of illness, so of course the neutrophil count go down and the lymphocyte will come down in terms of cell. So first I think TBM will be the first.
So in the absence of any evidence of a TB meningoencephalitis, as we have added antibiotics and antiviral empirically, should we think about sending the treating with the empirical AKT in this case? Is a question to both the infectious disease specialist and neurologist.
So nowadays there is no generally empirical treatment. If your syndrome is fitting, then we treat it as a presumptive TB.
Yeah, that's what I'm saying. So you
yeah,
label
possible.
it whatever,
Yeah, possible.
presumptive
But
or possible,
here,
but then should we
here,
add anti-tuberculous therapy or we still do
but
more
sir,
hunting?
Sir, here there are no any basal exudates or anything. MRI picture is not typical of TBM. It's only just like it's increase in the enhancement of this thing.
Correct. So this is a meningitis for sure.
Meningitis.
This child is also having some behavioral abnormalities with meningoencephalitis. We are not able to pick up the TB from anywhere as of now.
Yeah.
Should we treat with the ATT or wait for disease to evolve is my question.
I think we have to try to search more evidence for the TB anywhere
How
else
do we
in
do
the
that?
body.
How do we do that?
Yes, so we can screen the body. If we can see is there any lymph node or is there any chest findings or like mediastinal lymphadenopathy is there.
So on
CT chest.
clinically nothing, suppose, then do we do a whole body CT or CT abdomen or chest, or I mean what kind of investigation? PET CT or?
I will not go for the PET CT upfront because lot of radiation. I will suggest CT chest with contrast and we'll look for any evidence we can find mainly in the, is there any primary evidence of TB in the chest or in the mediastinum.
Yes.
Correct. So I think let us progress the
No,
case and
just
we'll
one. As a simple pediatrician, I would start AKT and discontinue it if there was no evidence.
Now, my question is, what is the indication of steroid over here? You are thinking of TB doesn't mean it is TB, right? So first thing is that search for TB, treat for bacterial meningitis. Search for TB, treat for bacterial meningitis. Getting better, it's bacterial meningitis. Not getting better is tuberculosis.
in what?
Because right now, so we'll come to viral. It's a subacute meningitis. Viral meningitis usually are acute. First thing is that. Secondly, the CSF picture is not like a viral meningitis. Bacterial meningitis is still possible. Tuberculous meningitis is still possible. At this point, I don't think there is any indication to start steroid except for like acute bacterial meningitis, where we give dexamethasone to prevent hearing loss, but ideally has to be given in first 24 to 48 hours. So overall, there's no indication as of now. As of now, whatever evidence we have.
While we are waiting for the primary tuberculosis focus, in the interim, you have already started a ceftriaxone with acyclovir. Why not, like old school, repeat a CSF after 48 hours and see whether the pleocytis has worsened, the proteins are static or increasing. If they are increasing, we are bang on TB again.
And considering the duration of illness, especially for a pyogenic meningitis, I think this is definitely a prolonged duration of illness.
I agree.
So I think the TBM comes definitely first on the list
I
rather
agree.
than a partially treated pyogenic meningitis.
I agree with that.
And rather than investigating further for any other causes, I mean, it
Right.
more or less fits into a TBM with its onset,
Right.
duration, progression, and the
what
signs
is-
which are seen.
What is biasing my opinion is the MRI picture. MRI picture is like a acute bacterial meningitis. It's still not showing a typical picture of a tuberculous meningitis. It may be purely tuberculous meningitis. I don't say that it may not be, but it's not a typical picture for a tuberculous meningitis. Right now, that's what I said. You search for TB. TB is first. There is no doubt about it. I don't think anyone is debating it.
So the point of all discussion is that should we add anti-TB therapy?
No, anti-tuberculous treatment, as far as I know, is not that of a emergency per se. Someone raised a point that steroids. Suppose this is acute bacterial meningitis, and you're giving high-dose steroid. What would happen?
Hey, what the audience is saying that, as it is, you have given antibiotics empirically.
And
Antivirals
yeah.
empirically. So why not give AKT
How
empirically?
does
And
giving
one
AKT
minute. And he is saying that steroids, because you are treating empirically a CNS infection, and so why not give steroids?
No. First thing
Because
is
you are not treating it's a CNS tuberculosis. So Dr. Hendre's point is then why not give a steroid also?
so
Because here everything is going empirically.
no.
You are covering with antibiotics.
First thing is that we are not giving antibiotic empirically. We have evidence on CSF and we have evidence on MRI that it is meningitis. We have evidence on even history that it is meningitis. The debate is whether it is bacterial, partially treated, or tuberculosis. Someone made a point that this is a subacute meningitis. So yes, I agree with that, that tuberculosis is first in line. But is giving AKT an emergency is a question. Will giving AKT for 7 days help the child? Giving AKT is not an emergency. Point over here is, will steroids help? Because we are not, so are we giving steroids? Why are we giving steroids over here? Point of giving steroids in tuberculosis is to limit arachnoiditis and limit, if there are any tuberculomas, we have to reduce the perilesional edema. Over here, there is no, evidence of arachnoiditis or anything. So point is that. So right now we are what I would do is
Even
that
the further adhesions, fibrosis. And
so that's
other
for
things.
arachnoiditis.
To our surprise.
There's nothing, na? There's nothing.
But why not give AKT?
Yes,
Why not give AKT? So 40 years ago when I was doing residency, our first thing was we would give AKT. Then some years later we started AKT with steroids. Then some years later we were giving Empirica when we had no diagnosis, no bacteriological. We would give AKT, steroids and anti-malarial. And now there's a time we give AKT, steroids, antiviral and perhaps...
Antibiotic.
Yes, ma'am.
Antibiotic. I think
Ma'am, to
this
our
child is bad.
surprise, CSF BioFire for meningoencephalitis panel detected HHV6 virus. Her CSF culture did not grow any bacteria. So what is the thought process now?
Just take a count. How many people would not give AKT?
Not give AKT.
How many would give AKT?
Any significance of HHV6 virus in the CSF of this child? Rushabh sir.
So she is how old? 9.
9 years old.
So
Otherwise
HHV6 encephalitis per se is usually seen in immunocompetent children less than 3 years old, and they can present with mild febrile illness with encephalopathy. Many of them can present with febrile seizures. Many of them can present with febrile status. So that is how HHV6 may present, but many of them present with mild febrile illness, that's all, no CNS involvement. After that, HHV6, like other herpes viruses, it can remain dormant in CNS. So CNS is a reservoir for HHV6. So many a times when we have cells in CSF, we may have HHV6 which is positive, because this DNA gets integrated with the, it's not just CNS, even the peripheral blood cells can be the reservoir for this thing. So HHV6 presenting as a subacute encephalitis is very unlikely in an immunocompetent child, and we can take it to be HHV6 positive because the CNS is the reservoir over here.
And is the treatment necessary or not?
So this kind of HHV6. No, it won't go against the tuberculosis, but if you see for the tuberculosis to define, first it's only day 9 and the child is, if you consider the child was not have still any seizure, it could be in stage 1 TBM if we want to say.
But if at all enhancement happens, it happens only predominantly in basal meninges in tuberculosis.
It can happen anywhere, but morely in the basal exudates and all that. Second thing regarding this HHV6, it could be chromosomally integrated HHV6, which is a terminology where, as Dr. Rushabh said, it can be persistently in your blood cells, peripheral cells or other cells. So simultaneously, if you do blood PCR and if it's positive or there is a difference more than 1:5, then only you can treat and consider it as a real HHV6 infection. Otherwise, it is, you just don't have to treat the infection.
Tuberculosis, oh sorry.
Sorry,
Can I
just
just
go-
add something before for the question? Tuberculous bacilli and the rich focus is commonly seen in basal cisterns, and it can either burst into the parenchyma, into the vessel or outside the vessel, and that is how we are going to get a meningitis. That's why we usually get meningeal enhancement and exudates in the basal cisterns, and that's the cause. Usual bacterial ones are the ones which you involve the cortical this thing. So So that's why I was more fixed with, we treat this thing as a bacterial and keep searching for tuberculosis.
So
Hello.
HHV6,
Just to go back to
BCG
the
scar was present, sir.
just to go back to the discussion which was going on about empirical AKT, I would like to say 2-3 things. One is what Madam said 40 years ago when we were residents. I agree with you that we would have empirically started AKT. But now the current trend and the current recommendations that even pulmonary coughs, unless you document bacterial isolates, you don't start AKT. So where is the question of
Because
starting-
pulmonary is not a possibacillary, whereas CNS TB
No,
is a possibacillary state.
So you will start
So
empirically 4 drugs.
if
I
4
think
drugs,
it-
yes, I would.
I don't think Dr. Suhas Prabhu or anybody
Yeah.
here of infectious disease specialist will agree with that. Number 2 is in a 9-year-old, see, tuberculous meningitis, I am worried if the child is younger because I am worried the child may become deaf, the child may have mental retardation and hydrocephalus and so many other complications. In this case, this is a 9-year-old with a normal looking MRI, not showing any hydrocephalus or anything. There is not very high number of leukocytes in the CSF. I will hold on to AKT because
I
this
respect
AKT
your opinion.
I'm so sorry, but we will take the personal question after the session is over. So on day 3rd of admission, she started to show onset of new neurological symptoms like disorientation, aggression, and agitation. She was not able to recognize her parents, and there was sudden onset mutism. She was agitated with severe headaches. Vomiting episodes also were present. So what could be the cause of such symptoms in this patient? Rishabh sir.
Now we are discussing about tuberculous acute bacterial. This is something which we don't commonly see. These are neuropsychiatric symptoms. She has disorientation, which is a neurological symptom, aggression, agitation, behavioral problems, difficulty in recognizing parents, again a neurological symptom, and onset of mutism. So this is a neuropsychiatric syndrome which has started over here and which is very unlikely of a common bacterial or a tuberculous meningitis or meningoencephalitis presenting. So in such a scenario, definitely I would start thinking about an infection which has triggered autoimmune encephalitis. She may have started with an infection, but right now, that infection may have triggered autoimmune encephalitis because now she doesn't have any fever. When
Yes,
she
no
got
fever.
admitted, she is not
Yes,
having any
since
fever
admission,
right
no
now.
fever till
So
this
there
point.
was an infection, there was a meningoencephalitis, and many a times we do get meningoencephalitis which triggers autoimmune inflammations. So, like for example, you have HSV1 which can trigger. So that is one thing which I would think of.
So in view of new onset CNS manifestations and rapidly progressing CNS symptoms, possibility of autoimmune encephalitis was considered and we started her on the treatment for the same. Her CSF sample also we sent for autoimmune encephalitis panel to Kochi. MPS, steroids and IVIG. She was started on pulse dose MPS, 30 mg per kg and IVIG 1 gram per kg. She was shifted to PICU, antibiotics were upgraded, levetiracetam was prophylactically added. After her first dose of MPS and IVIG, she showed a quick response in terms of less aggression and less agitation. She started speaking and recognizing the parents. She regained her orientation in time, place, and person. On day 4th of admission, she received the second dose of MPS and IVIG. Her USG abdomen plus pelvis was done to rule out any ovarian teratoma, which can cause, which can be present in autoimmune encephalitis and which can cause it. On day 5 of admission, child had bradycardia and intermittent hypertension. She developed squint, again headache with excessive sleepiness. Her management of raised ICP was done. With the understanding that autoimmune encephalitis can cause such kind of autonomic changes, her treatment with pulse MPS was continued. So third dose was given and we planned to give it for total 5 days. With the possibility of CNS SLE because of neuropsychiatric manifestations as one of the rare differential diagnoses that can present in young pre-teenage girls, workup for SLE was sent. So CBC was near normal. CRP, ESR were normal. Her triglycerides were 93, normal. Ferritin was normal. LDH also came out to be normal. Her urine protein creat ratio was high. On day 6th of admission, her sensorium was waxing waning with diplopia and irritability. New onset fever spike started. Sodium was persistently low with high urinary sodium. So we managed her for cerebral salt wasting. Autoimmune encephalitis panel had come by that time. It came as negative. ANA blot test, which we had sent for workup for SLE, came positive. ANA came positive, plus anti-RO antibody also came positive. These are the reports. Autoimmune encephalitis panel is negative. ANA is positive, and anti-RO antigen is positive. So what are the thought process now? Is it CNS SLE?
See, we started with her having meningitis, meningoencephalitis.
Yes.
Then she developed neuropsychiatric symptoms. So if we are talking only about neuropsychiatric symptoms, if we see the diagnostic criteria of autoimmune encephalitis, the last criteria is to rule out, if you are thinking of a systemic connective tissue disorder or an immune disorder. So SLE psychosis is a differential diagnosis for autoimmune encephalitis, definitely. But the point over here is there are no other features of SLE which are there present. And SLE presenting with pure psychosis is possible but is rare. Secondly, she has presented with meningitis first. Now, SLE presenting with meningitis is very odd. I mean, like I think reported is only 1 to 2%, less than 1 to 2% actually. So that is another thing. Third thing is that the ANA is just 1:100, which can be positive in many people, 1:100. So that's not very diagnostic. And anti-RO is not the most diagnostic. I think it's most of SM and DSDNA and all those. Yeah. So SLE is lower down on the cards. We'll still keep autoimmune encephalitis, seronegative autoimmune encephalitis being presenting like that. Another possibility is there is an overlap between the MOG and autoimmune encephalitis. So MOG can cause meningitis and autoimmune is causing so there is an overlap syndrome, MOG and MOG and NMDA overlap syndrome which can cause. But with the proteins being so high and cells being so high, still we will keep the possibility of, and she's not getting better now with antibiotics. So now I would think seriously about tuberculosis.
Yes, sir. So on day 7th of admission, child had waxing waning sensorium with significant irritability with lateral rectal palsy, unequal pupils. Repeat MRI showed hydrocephalus with periventricular ooze, marginal interval decrease in the leptomeningeal enhancement. In MRI, we also found out a necrotizing paratracheal lymph node. So we got CT chest and abdomen done. CT chest showed necrotic paratracheal cavitated lesion with the thick wall measuring 3.5 by 3 by 3 centimeter. Also observed calcified subcarinal lymph nodes. CT abdomen showed mild hepatosplenomegaly. So we sent we did CT guided biopsy of paratracheal lymph node, and which was sent for gene expert.
This necrotizing paratracheal lymph node was found in MRI of the brain.
Incidentally, we took the lower sections also.
Okay.
No, previously. So MTB was detected with rifampicin resistance. We sent it for drug sensitivity or resistance testing. So isoniazid resistance was not present, and other second line TB drugs resistance also was not present. In the pyrosequencing, we came to know that polymorphism for fluoroquinolone was present. So any significance of this polymorphism?
So polymorphism is a kind of a mutation where you can see the increase, decrease or no activity of any enzymes. It's very difficult to say whether it is a full-fledged like 100% mutation or there is no mutation. But definitely we cannot take it as a resistance unless and until it is resistant detected. So it could be any possibility.
So should we treat this TB as MDR or XDR, sir?
See, nowadays, if you treat any TB, the treatment will be same like for a MDR or XDR.
The duration
So
will
yeah,
change.
so the duration, and once your final MGT culture will come, and if that is showing any fluoroquinolone resistance, then we can add the different drugs like say, class C drug like a delamanid or other ethionamide and distinct drugs we use.
No, X-ray test was normal.
Did you send a midget test initially with the
Midget was sent.
negative?
It was negative. The slides
Actually,
are not
midget
going
report will
ahead.
come after,
It's not going
final report will come after 42 days. So this is a pyro sequencing, so report will come in 48 hours.
In this child, you mentioned about a high albumin creatinine ratio in the urine sample. How do you explain that in this scenario now? Is it possible that this child has a tuberculous kidney affection also?
So to rule that out, we sent urine AFP and gene expert also, urine routine also later on again, which came out to be negative.
Then what was the reason for
Previously, we were
high
thinking.
protein creatinine ratio? In the
Previously, we were thinking it was because of autoimmune disease or SLE or Sjogren, but then later on that possibility also we ruled out. After steroids, yes. Febrile proteinuria.
I mean,
Any infection.
so but once protein. I mean, in such a situation, it's worth repeating it rather than kind of
I think,
quantifying is important.
Sir, what is important in this case is, I think we are looking at things which are not that important in the larger picture here. What we have now, after the end of so many days wasted, not wasted, you went after too many organisms, right? So this is my personal experience. See, TB to document microbiologically is one of the most difficult diseases, correct? Now, if you insist upon documentation, then I think you need to have a good representative tissue sample or a good representative sample. CSF, even gene export yield is very poor. So that negative, I will never be discouraged. That is why I said that here, first issue was localization. That was done immediately, that it is CNS. Infection was confirmed. Now it was the only issue was, what is the cause of that infection? Now, in the bargain, we went after that CSF panel. I thought that to go after TB, the best place, because this otherwise is a PU. Yeah, exactly. So it is a PU. So I think a takeaway message is, if you have a PU or a fever without localization in today's era, try to search the mediastinum. Now, if you are saying the X-ray chest is normal,
No.
parenchyma you are looking at, just look at the mediastinum, you will definitely see a slight widening. That is a clue, especially in the old child.
So in the absence
I think,
of any...
I think a CT of the chest done little earlier, probably before going on to the immune-mediated meningoencephalitis and all that. And still the question remains about high albumin creatinine ratio, which is very difficult to explain. And it was reported as more than 3, if I remember correctly, which is very, very high quantity of albumin urea. So this child's 24-hour urinary albumin should also be done, and a repeat protein creatinine ratio should be done.
So it was
an
done,
error.
24 hours was
Because
done,
that
it
is
was still
something
high.
which just cannot be explained by
So if
our
I may,
postulate.
if I may understand, as a primary care pediatrician or a clinician, there are so many odds in this picture where we do not know why this child's ANA, even if we consider ANA being positive in 20% population, why the child's Rho is positive. Number 2, why the child is having a proteinuria. Number 3, if we ever see a similar scenario in future, child is having a meningitis, and if you are not able to figure out on clinical history examination or by family screening a TB, should we think about doing a CT, abdomen and the chest as a screening tool to figure out localization of TB? Because that's what he's trying to.
Yes, I think that
So
is
that's
the
a-
more
So that's a take-home message for all of us, and let us go ahead with the case.
So we started her with XDR TB treatment. tab leofloxacin, cycloserine, linezolide, and capsule clofazimine along with amikacin was started. Plan was to start bedaquiline. So any specific investigations which are to be done before starting bedaquiline, Dr. Rishabh? Amol sir.
Okay, so before starting bedaquiline, we have to certain test prerequisite where we have to do CBC, LFT, RFT, then serum electrolyte, magnesium, calcium, 2D echo, 12 lead ECG, ophthalm reference, and psychiatry reference. So these things are mandatory.
Yes.
And
So-
if the adolescent girl, then urine pregnancy test.
Yes. So that everything came out
But
to be
why,
normal.
but why was it not started in this child?
So
Started.
basically, bedaquiline is not freely available. It is available at the government institute. And once your all tests are normal, then only bedaquiline will be prescribed to the patient. So bedaquiline was yet to procure from the government hospital. So before that, the other drugs are available in the other pharmacy. So that's why the bedaquiline was awaited and other drugs were
I
started.
think we could start on the 6th or 5th day of the AKT. First 5 days we could not procure because of the logistic issue, but we did start on the 6th day.
To rule out pulmonary TB, gastric lavage AFP and gene expert were sent on 3 consecutive days, which turned out to be negative. In view of proteinuria, urine examination also was done to rule out renal involvement. So urine gene expert and AFP also we sent, which turned out to be normal. Child was showing symptomatic improvement after starting AKT. Other antibiotics were stopped. So later on day then the usual ICU-related illnesses. Child had persistent fungemia with Candida tropicalis, and DVT was developed, which we treated. MRI brain and whole spine screening was done, which showed persistent hydrocephalus with periventricular ooze, but significant decrease in the leptomeningeal enhancement. Child was vitally stable, no fever spikes, squint was improving, oral intake was improving, there were no setbacks. So child was discharged home on AKT and other medicines. Take-home message: frequent assessment of signs and symptoms of patients is crucial for evaluation of progression of disease, and multiple differential diagnosis should be kept in mind till the final diagnosis is established. Presence of HHV6 virus in CSF of immunocompetent patient does not warrant initiation of any antiviral treatment. Tuberculosis, being endemic in India, often remains high on the list of potential causes even if initial tests come out to be negative. Thank you.
Don't start.
Normally, what is our policy? Every X-ray, we look at 45-degree angle and look at the coronal angle. If it is obtuse, we know there is something sitting there, and we go for a CT scan if required. So if we could have, in the hindsight we are discussing this, but if we could have done that earlier, probably would have picked it up earlier, as he rightly mentioned it.
We saw the X-ray later on also, it was looking normal only that time also.
But mediation, the coronal angle, if it is obtuse, you know, there is a lymph node sitting there. That could be one of the things which can pick up.
And please don't start empirical ATT. Now the government program is also not starting any empirical ATT unless and until there is evidence. So that is a rule governed by the government.
I think there is a probable TB diagnosis also which is available, and at times we may get no evidence of TB and we still do start AKT. So I think I would not agree with you.
So what I am saying, yeah, so what, no, what I am saying, if you have symptoms, clinical symptoms, presentation like fever more than 14 days, cough more than 2 weeks, or loss of weight, your gene expert is negative, but your CT suggests you of like a trine bud appearance or any lymph node, and you cannot take the evidence, you cannot do the biopsy, or your IGRA is present, MONTU is present, those evidence are there. At that time, we consider it as a presumptive TB, and on that basis, we can start empiric TT. I am not saying you cannot start. You can start, but yeah, it's presumptive.
See, this child came on 9th day. Are we going to wait till 14 days? This is a disease in progress if it is TB. So I think it is TB in progress, and at 9 days you can start. At 14 days, if something else comes positive, I think we can discontinue that TB. But we can agree to disagree.
Good afternoon, everyone. Myself, Dr. Samir Rao. I am intensivist at Bethany Hospital
Hello.
and consultant at Surya Chembur. Coincidentally, my case is also 9 years old female child.
So is the diagnosis TBM?
So that we will not disclose now. So this female child came to our casualty with not responding appropriately since 3 to 4 hours, preceded by a short history of fever, loose motions, vomiting, loss of appetite since three days. So child was apparently all right 4 days back. Then she had mild to moderate grade fever up to 102, which was intermittent, not responding to responding to antipyretics, and she was normal in interfebrile period initially. No chills, no rash over body. Vomiting was non-bilious, non-projectile, 1 to 2 episodes per day, usually after meals and after taking medication. Loose motions, 3 to 4 episodes per day. Watery, loose, foul smelling, no blood in stool. She was not responding appropriately in the form that she was having irrelevant talks and excessive sleepiness since 3 to 4 hours before coming to hospital. Urine output was average once in 6 to 8 hours, and there was no history of trauma, otorrhea, headache, convulsion, unconsciousness, or any focal neurological deficit. Past history, she had a short hospital stay of 5 days in view of pneumonia. She recovered completely, and the investigations and reports were not available. Birth history was normal vaginal delivery, full term. Immunization history, immunized completely. Developmentally, she was normal. Family history also, no COX contact. So with this history and the case scenario, I would like to ask Dr. Anjali ma'am.
No, second slide. I mean, so fever, vomiting, loose motions, I would think of a gastrointestinal infection. The only thing is that now she has become dull. So whether for 3 to 4 days, and if you see her urine output once in 6 to 8 hours, that seems a little less for a 9-year-old. So I would think that she has a primary some bacterial or viral infection for the first 3-4 days, and now she has some secondary metabolic this either hypoglycemia or dehydration and hyponatremia or some other metabolic reason for her obtundation, because there is no seizure and there is no localization.
So on examination, she was sick looking, thin built, drowsy and irritable intermittently, disoriented. Pulse was 104 regular, respiratory rate of 18 per minute regular, 102 by 62 was the BP. There was signs suggestive of mild dehydration, BCG scar was there. Weight was less than 3rd percentile and height was normal. SMR was pre-adolescent stage. GCS was 10 to 11 by 15. Tone increased in bilateral lower limbs, brisk deep tendon reflexes with Babinski's sign positive in bilateral lower limbs with ankle clonus and neck stiffness. No cranial nerve involvement, pupils equally round, reactive to light, and no involuntary movements were there. No other systems involved. So other systems were normal. So with this background history and examination findings, what could be the possible differences?
So neck stiffness, so there's definitely some CNS involvement. Now I just wanted to see if it is of acute onset or it's this. Some two incongruous things I find is that the respiratory rate is only 18 for such an abtunded child with a pulse of 104. So whether this child is bradypneic and, therefore because of CNS raised tension or something, or whether there is some ketosis or something like that. And the other thing is that her weight is 18 kgs at 9 years, which is so something chronic going on, but only her height is very good, 129 centimeters, which seems to be in the normal limit. So there is something acute that is going on, and not for a very short while, but for quite some considerable time perhaps, because her weight is much more severely affected.
Yes, ma'am. So we also considered.
So some kind of meningitis in view of neck stiffness.
Yeah. So we also considered meningoencephalitis as our initial working diagnosis with other DDs of space-occupying lesion, diabetic ketoacidosis, envenomation, and acute gastroenteritis with dehydration, like venous thrombosis or something like that. So out of which, because the respiratory rate was very low, there was no acidotic breathing. So diabetic ketoacidosis was kept, back of the list. And the other meningoencephalitis was our working diagnosis.
Envenomation also they cause hypotonia. Your child has hypertonia.
Yes. Yes. Upper limb, upper limbs were normal. The reflexes also. Yes, sir. Yes. Yes, sir. So after initial management, we shifted the child to PICU, and then we started NS bolus, followed by maintenance, 3% hypertonic saline, and HGT was monitored. We also gave a loading dose of ceftriaxone, followed by maintenance, and a loading of levetiracetam, and followed by maintenance. Labs initially showed, CBC showed mild anemia with leukocytosis, more of neutrophilic, and platelets were normal. Electrolytes showed hyponatremia of 126.8. Other investigations like gases were normal, liver function test, renal function test, CRP was 0.5 only, rapid malaria antigen test and NS1 dengue was negative, urine RM was normal, chest X-ray was normal, and cultures were sent. So, but fundus showed papilledema, so we could not do CSF on day 1. Now, so what neuroimaging modality of choice should be at day 1 of illness in such a patient? My question is to Dr. Rishabh, sir.
So before going to neuroimaging, we need to know what to scan.
Yes,
What neuroimaging, before that we need to know what to scan. So this child has come with raised ICP features probably, and child is encephalopathic, right?
Yes.
And child has got only lower limb involvement.
Yes, sir.
Okay. So when we have only lower limb involvement, usually the involvement is spine. But with a child with a spinal involvement should not have features of encephalopathy or papilledema and all those things. Secondly, if it is not, of course, spine, you may have a neurogenic bladder where you'll have high, urinary incontinence, there will be increased frequency, there will be urgency, there will be precipitancy, and 9-year-old child can definitely tell all these symptoms if you ask. So that is one thing. So spinal involvement looks unlikely over here because of this absence of certain signs and presence of certain signs. So if it is not spine, then it has to be brain. If it is brain, then there are 2 or 3 sides. One is if it is paramedian sagittal cortex, which supplies the lower limb. But again, she should not have papilledema and all those things. Finally, it could be a periventricular white matter involvement. So periventricular white matter involvement will cause both. If there is a ventriculitis, there is hydrocephalus, or there is, say, some space occupying lesion over there in that area, you may get only lower limb involvement with alteration in sensorium and papilledema. So that is where I think the localization would be. Secondly, what imaging, actually, if you ask only about this child is a different thing, but I think overall it is a case-to-case basis decision. Because what is the sensorium, how is the child hemodynamically, whether you have a neuroimaging modality in-house or you have to transport the child, whether you have someone who could accompany the child, could resuscitate the child, whether there is an anesthesia backup, all these things are very important to take into consideration what neuroimaging you want to do. Right now, if you think this is raised ICP, I am thinking of a ventriculitis or I am thinking of a hydrocephalus. CT scan is good enough for this child because I just want to see if there is hydrocephalus, if there is ventriculitis or no. If there is none and there is something else, then I will require MRI. Overall, if you ask me, if the child is hemodynamically stable, if the child is, mild encephalopathy, you have got a in-house MRI facility, you go for MRI because you don't want to do two imagings. But if the child is deteriorating, you have to put the child on inotropes, the child, sensorium is going down, he has to be intubated because of low GC score, then over there, definitely you would go for a CT scan. So there is no one answer. What is the availability? How is the child's sensorium? How is the child hemodynamically? All these considerations need to be taken into account. For this child, I think if the child is good, 10, GC score is 10,
Yes, sir.
and otherwise hemodynamically the child is fine, and you have a good backup, you have in-house MRI, I would do a MRI. But if you don't have an in-house MRI, you have to transport the child, maybe you could do a CT scan with a contrast.
So we did MRI plane, large lobulated SOL in the left basifrontal and anterior gangliocapsular region was seen. There was extensive perilesional white matter edema, and there was significant mass effect with contralateral side midline shift. Restricted diffusion seen in the temporoparietal and bilateral frontal lobe cortical gray matter suggestive of meningoencephalitis. So we continued with the same management, and there was clinical improvement, no further vomiting. GCS also improved to 14/15, and reflexes still brisk with ankle clonus. Fundus was normal, so we planned for CSF. CSF suggestive of, it was colorless, protein 32.3, sugar 50.
Ideally, I would not do a CSF in this child. This is the place where I would start AKT without doing CSF.
No, no. This was after a neurosurgeon also was involved, sir. This was done on day 4 of the.
Yeah.
Attempt a CSF. I mean, there is no second thoughts about that.
Yeah, true. Agree.
So RBCs were 12, WBCs 110 with lymphocytes 96%. Gram stain was no organism grown. Gene expert AFB not detected, and cultures were sent. MGIT was sent. So now, what could be the possibility at this moment?
Can we go back to the MRI, previous MRI? See why I said, as sir said that even I would not attempt a CSF in this child. Definitely there is a midline shift. So there is a possibility of a cerebral herniation over here. What we are seeing is that first image is a T1 image where you are seeing a hypointense mass with peripheral hyperintensity, and then the next scan, I guess, is a flare where you are seeing a very hypointense mass. So hypointense is dark and hyperintense is white. So such a picture usually is infective, and your MR spectroscopy is showing lipid lactate peaks with low choline. So over here, one is cerebral abscess, another is this thing here, tuberculoma. But for cerebral abscess, you should get some amount of central hyperintensity, which is not there. So then, most likely it is a tuberculoma with a perilesional edema, which is causing stretch over ipsilateral periventricular white matter, and it is also stretching the contralateral basal ganglia and periventricular.
Why not a lobulated cysticercus?
So cysticercus is not so large. One thing. Secondly, intraparenchymal cysticercus usually are not loculated. They are cisternal cysticercus, which can give you a racemose appearance. Secondly, you look at the margins are a bit irregular. Thirdly, T1 is showing a T1 hyper intense or a bright capsule, which is not usually seen in cysticercosis. Okay.
So we also kept tuberculoma as our primary diagnosis, and then neurocysticercosis, tumefactive ADEM, brain abscesses and primary neuroectodermal tumors were other differentials. So,
So we thought,
so sir, if you can guide us on how to diagnose other.
so we thought that we would discuss a bit on ring enhancing lesion and what they look like, and can we really differentiate them on MRI, which would have been a good point to discuss amongst all of us. So first, as madam said, that neurocystic sarcosis is small. It's less than 20 millimeter or 2 centimeter usually. It is at cortical, so it's usually in the cortex between the gray-white matter junction, so juxtacorticular. This is a T1 image with a contrast. So what we are seeing over here is that there is a bright dot at the center or usually they are eccentric, so they are away from the center. That is a scolex, and we have a ring enhancing lesion like picture with a central darkness on T1. This inverts on T2. T2 becomes bright and the dot becomes dark. So that is how we are going to think of a neurocystic sarcosis. So then another thing is we have toxoplasmosis. Toxoplasmosis also can cause a similar picture, but toxoplasmosis, when we see on T2 imaging, we have something called as a triple rim sign. So there is a central hypointensity, then there is a peripheral isointensity. The biggest lesion over here is showing a triple rim sign. So we have a central hypointensity, middle isointensity, and then there is a hyperintense. So that can go more in favor of toxoplasmosis. Then this is tuberculomas in various phases. So what happens is that even NCC and tuberculoma, both of them to begin with are they're dark on T1 and they're bright on T2. As the tuberculoma progresses, there is a central caseation necrosis, and we start getting, in the third image if we could see, in the second image if we could see, that we start getting central hypointensity or central darkness. And as this tuberculoma progresses into a tubercular abscess, again we start getting a central hyperintensity or brightness. That is a sign of a tubercular abscess as against tuberculoma. So we don't see a eccentric node or scolex in tuberculoma. Tuberculomas are big. They can be conglomerate. Borders can be nodular. Tuberculomas usually have T2 hypointensities. NCCs usually have T2 hyperintensities. Fine. So that lipid lactate peak is usually high in tuberculomas. So cerebral abscess, any cyst in the CNS, ring enhancing lesion, is to be taken as a cerebral abscess unless proven otherwise. Okay. So what is the difference between a cerebral abscess and a tuberculoma? Both will have a T2 dark center, but as the caseous material turns into pus, it becomes bright. So then T2 darkness turns into brightness. So tubercular abscess, cerebral abscess, fungal abscess, they all look the same. They will all have high lipid lactate peaks. They will all have diffusion restriction. But difference between a cerebral, you have bacterial and tubercular versus fungal abscess is that fungal abscess will show fronds. They will show hyphae. So they are showing a hyphae which are going in the middle of the abscess. That is one thing. Another thing which could differentiate is MR spectroscopy. So MR spectroscopy in a bacterial abscess will have amino acid peaks along with lipid lactate peaks, while tubercular abscess will not have amino acid peaks. So that is the differentiation between the three. Then another thing which comes with a ring enhancing lesion is tumefactive demyelination. So tumefactive demyelination will also have a ring enhancing lesion like quality. It will be hyperintense on T2 as against tuberculomas and abscesses which are hypointense on T2, and they will have incomplete ring. The ring will be incomplete. They will not have a complete ring on the contrast enhanced picture. So that we are seeing in picture number D. And then another one which is common is glioblastoma. Glioblastoma can also have a ring enhancing. This is a cystic glioblastoma. So over here also it is showing T2 hyperintense in the center and hypointense. And then the question is whether it is tuberculoma or whether it is glioblastoma. So both of them will have lipid lactate peaks, but tuberculoma will have low choline, glioblastoma will have high choline. So that, I mean, we have to, mix and match T1, T2 images, diffusion images and MR spectroscopy images to know what exactly it is. Size helps, the picture, regularity helps in some cases, but most of the times it is not so simple. We have to go with multiple imaging techniques to know that. And this is CNS lymphoma. CNS lymphoma is easy. It is ring enhancing and it is T2 homogeneous bright.
So on day 5, we did MR brain spectroscopy, which suggested that there were tall lipid peaks with small choline and N-acetyl aspartate peaks, reduced N-acetyl aspartate to creatinine ratios, and reduced choline to creatinine ratios suggestive of tuberculoma, enhancing leptomeningeal thickening suggestive of meningitis. So there was tuberculomas along with meningitis. So AKT CAT1 was started along with pyridoxine. Injection dexamethasone was continued, and then the rest of the treatment continued. Child improved clinically. Other sites for primary focuses were screened, where GL for gene expert was negative, X-ray was normal, HIV 1 and 2 was non-reactive, but USG abdo suggested there was enlarged periportal and peripancreatic lymph nodes, largest being 3.2 by 1.6 centimeters, and enlarged mesenteric nodes 1.6 by 1 centimeter, thickened ileum and mesentery suggestive of abdominal cox. 2D echo was normal, but as there was no window to get the sample, biopsy could not be done. So in the second week, child improved clinically. Yes. Yes, sir. Yes. And the child continued to have brisk reflexes and ankle clonus. Blood culture and CSF culture was no growth. Child was discharged and compliance was ensured, but continued to have the upper motor neuron type of signs. No, at this moment we did not do. But later on, as we, after the treatment follow-ups, we did MRI screening. So coming to that thing, after 3 months of AKT, child clinically improved but persisted with brisk and ankle clonus. Appetite improved, weight gain was there. MRI follow-up was done, which showed mild reduction in the primary tuberculoma with increased wall thickness, fairly unchanged edema, but new conglomerated granulomas were seen on the left side in anterior temporal pole and along the left sylvian fissure abutting and partially encasing the left middle cerebral artery. On right side, there were new granulomas in the frontal, parietal, medial and occipital regions, and there was enhancing leptomeningeal thickening along the basifrontal region and sylvian fissure. So at this moment, as there were new granulomas seen, what possibilities could be there? So these were this was the MRI after 3 months, where there new lesions could be seen in the left side as well as on the right side.
So how was the child? Means like child is improving symptomatically, weight gain is there.
Child improved clinically, weight gain was there, appetite improved, but continued to have ankle clonus and brisk reflexes.
Is there fever?
No, no fever.
Okay.
MJIT was no growth.
Okay. So here like we are having a clinical symptoms, radiological changes, but no microbiological evidence, and we are treating it as a tuberculoma. And child is improving on the ATT. There is no deterioration. So there is, meanwhile, there is increase in the number of tuberculomas without any fever or anything. We can take it as a paradoxical reaction or iris. And second possibilities could be like if fever comes or anything, we should think of MDR TB. Like this.
Also steroids. So some clinical improvement is expected in this child. And therefore, in this child, we should go again all out, like Dr. Nadkarni was saying. There is a ileocecal tuberculosis there. You go get a laparoscopy, get a lymph node out. Get a bacteriological diagnosis. This child, we cannot just say that it can be iris. This we have to rule out. We just saw previous case whether there was a drug-resistant tuberculosis.
That was the motive behind presenting this case also, that we couldn't come to a bacteriological diagnosis as the family was not willing for a biopsy, the lymph node biopsy, the USG. And the child was clinically improving. So again, the things to go ahead with a bacteriological diagnosis was difficult. We were taking the opinion of the neurologist, we decided that we consider this as TB iris and go ahead and manage the child further.
Was CT chest done?
CT chest wasn't done.
Yeah.
Yeah.
Yeah, so most of the time, if the patient is not improving after 1 month or 1.5 months or 2 months, generally we consider it as a drug-resistant TB. But if the child is not ready for the biopsy, like any CT guided, but you can do the scopy and take out some sample from this thing. That could be more easy and that is not that much invasive.
They are just present. Is it a protocol to do a repeated CT or MRI in a child who's on AKT and improving clinically?
As in this case, we did not have any molecular diagnosis. We thought of doing it so that if there is something to add on, we can then switch to that.
Just a small observation here. Actually, I had this conversation with Dr. Amol in the break also. We had this experience. And in fact, why I would bet my money on iris is tuberculosis is a very favorable outcome when you start treatment in a presumptive TBM, like when you have leptomeningeal enhancement. They are in fact sort of localization. In fact, you have a TB meningoencephalitis without tuberculoma to begin with, and then you put the patient on AKT, you can have new tuberculomas. So I would still put my money on iris, right? So these tuberculomas are very notorious. Despite completion of therapy, they do linger on, right? So that was why I was discussing with Dr. Amol.
Yes.
So it is more of a disseminated TB. Yeah. But your iris is most commonly seen in extrapulmonary TB only. Yeah, so that's what madam was saying. The patient was not affordable and not able to. So the most simplest thing is do scopy and take the this.
So in view of TB iris, oral steroids and Livera was continued over a prolonged period. Almost 6 months we gave the steroids, and tablet aspirin was added to prevent stroke. It was continued till 1 year of treatment was given. Child, one MRI was repeated after 6 months also, which showed there was reduction in the tuberculoma sizes. And in the left side, basifrontal tuberculoma, perilesional edema and resultant mass effect gone. Reduction in the anterior temporal pole tuberculoma also. Near complete resolution of the enhancing component abutting the left distal perichiasmatic optic nerve and optic chiasma and left optic nerve. Right frontal, parietal, medial, occipital regions were no longer appreciated. Whole spine screen was done now, and then it showed meningeal enhancement in the lower lumbar and sacral region. AKT was continued till 1 year of completion, and there was further reduction in the size. So, and the last MRI scan showed no meningeal or cord enhancement, and then AKT and steroids along with aspirin was stopped. So my question to Dr. Rushabh sir would be point of stopping steroids and aspirin in such paradoxical reactions.
Well, paradoxical reaction, maybe Dr. Amol can answer it better. For
You talk, I will.
about aspirin, whether to start or not is a question, because there is no definite evidence that aspirin has got benefit. Now, there are only 3 or 4 RCTs which are done using aspirin in tuberculosis, and safety is very well established, but the efficacy is not established. So, the first RCT was done in India only, and they did not find a reduction in the occurrence of stroke, but they did find that it had got a survival benefit at end of 3 months. So, they used 100 milligram in adult patient with proven tuberculosis for 3 months. So survival, there was a short-term survival benefit. Second was RCT which was done in Vietnam, where they have used steroids at 84 milligram per day and 1000 milligram per day. And what they found is that the reduction in stroke is not there, and they used it for like say 2 months. But there is some survival benefit at higher dose of steroids, that is 1000 milligram per day. And plausible explanation given was they even checked for anti-inflammatory proteins in the CSF like protectins and resolvins, which were increased, and pro-inflammatory cytokines were reduced in CSF. So, but again, they have given it only for 2 months, and then there is only one pediatric study which does not show much evidence that steroid works either in reduction in stroke or in long-term developmental outcome. So right now we do not know how much steroid is to be given, aspirin is to be given. We do not know how many days we have to give. But if hydrocephalus is managed properly, if the patient is not a stage 3 tuberculosis and it is not a MDR tuberculosis, it's the stroke which causes a problem. So if you ask me, I use aspirin at 5 milligram per kg per day, because stroke adds to the neuromorbidity and adds to mortality. So that is another. So I personally prefer using, but there is no definite evidence or guideline.
Sir, as 6th month MRI showed meningeal enhancement in the spine also, do we need to do routine screening of spine at the onset of, diagnosis only?
Screening of spine, so the thing is that concurrent spinal and central, like brain tuberculosis is very low. It can be part of iris, but if we are getting a spinal cord signs, which I mentioned previously in the previous case, then maybe we will have to go with the spine. Secondly, arachnoiditis is known with paradoxical TB reaction. So if you are thinking of iris, then you screen the spine. That is what I would do.
To Amol, Dr. Amol sir, whether thalidomide has any role in regular iris or steroid resistant only?
See, thalidomide, there is one study from JIPMER where they were used thalidomide, but there are no clear-cut evidence on that. Thalidomide can be used as one of the supportive or adjunctive use instead of steroids. That is more in a brainstem meningitis or there is any optic chiasma involvement. Otherwise, I will not say any specific role.
Okay. So the takeaway where tuberculoma as diagnosis to be high on cards, even if the presentation is of short duration, though rare, tuberculomas can present as supratentorial space-occupying lesions in pediatric population, as in our case also, it was supratentorial, and frequent clinical and neuroimaging follow-ups should be done to rule out tubercular TB iris. Thank you. Sir, the nodes reduced. Yes. Thank you.
Thank you, dear faculty, for the very interesting case presentations and the exhaustive discussion on tuberculous meningitis that we had.